Thanks, Pete, for kind words. In the next 15 minutes, I would like to discuss some of the challenges which we face as surgeons dealing with cancers and how we developed a program next door in Dundee to answer some of these global challenges with certain implications for our local population suffering from this menace. Now, cancer is a global challenge, but there are absolute implications for Scotland because as we discuss things today here, there are 110 people who have been diagnosed with newly diagnosed with cancers. And that's not the only problem. The more challenge is that the Scottish population is aging, and in 2 decades from now, there will be more than 50% of people who would be having more than 65 years of age. And these are the people who are not going to afford the same kind of invasive treatment which we are offering them today, because they would be having multiple competing conditions, they would be on a lot of tablets, and more importantly, if you keep them in the hospital, they would suffer from a number of side effects, including infections, and some of them might not leave the hospitals. So there's a big challenge for us as researchers, as clinicians, and as public. How can we support some of the innovative ways by which we can address that challenge? We also know that some of people whom we make cancer-free have different sets of needs and support mechanisms. And how can we put that together so that they can support them on a long-term basis? You make them cancer-free, but you disrupt their lives, and how we can bring some minimal invasive ways so that there's the least disruption to their lives. And more importantly, there's two pushes which are happening at the same time. One is a technological push to bring to the healthcare, and second, the expectations of public is going up, and the resources are going to be limited, perhaps going to be less than what we have today, and how we can think in innovative ways so that we can transform some of the care which is happening in inpatient, which is very expensive at the moment, to outpatient, which would be better quality. At the same time, it would cost us less. So we need to focus. The prevention is the best way to do that, but no doubt detection remains the focus. Early detection remains the focus of any cancer pathway, because if we can detect the cancer early, we can treat them with intention to cure. But over the years, as surgeons and as people who are treating cancers, we have realized that detection alone is not the answer, because more cancers we detect, more treatment we do, and we realize that some of the treatments are unnecessary. For example, breast cancer, we remove 4 breasts to prolong survival of 1 woman. In the same way, I remove around 27 prostates to prolong survival in 1 person. The 26 people get unnecessary treatment, and you can imagine the amount of money the healthcare organization spends on their care. So that's a challenge for us to understand which cancers are going to be bad behaving cancers in the long term and which cancers are going to be good behaving cancers, because then we can channelize our resources and, more importantly, avoid unnecessary treatment. And with detection, you need to have characterization. That means we need to have a mechanism by which we can tell which cancer is bad and which cancer is good. And once we have diagnosed somebody with cancer, we need to have a mechanism of treatment by which it causes the least disruption to his living, and also it maintains his quality of life. And that's the focus of research program which we are running in Dundee. Let's take example of bladder cancer. The bladder cancer is diagnosed in people who come with blood in water, and we put a telescope using the light, same light which is on the roof and comes from the sun, and this is broad light. It has got a lot of wavelengths. It's a very broad light which we use, and we go into the bladder. If you look at the right side picture, there's something abnormal in the center, but otherwise you have a normal bladder. Even to the best eyes of expert, you can't say what's the extent of this area. Are there some other areas which have cancers which is small and hasn't been shown by the white light? We in Dundee and the rest of the colleagues across the globe, we focused on the research by using a chemical which is put into the bladder and using the metabolic pathway of the cancer cells. And this chemical is taken up by the cancer cells. And then what we do is we develop telescopes which had narrow wavelength, not the broad wavelength of the white light, but narrow wavelength around 450 to 480 nanometers. And we used those telescopes into the bladder. And you can see that you can see the cancer extent. Even the unaided eyes can see the cancer extent. And also it picks up more cancers. It has got two things. It allows somebody to treat that cancer effectively right at the beginning, plus additional small cancers are taken care as well. And that has a long-term implication because these folks don't need to come repeatedly for recurrence of cancer, and it would save a lot of money for the healthcare and improve the quality of patients. And that had a huge impact in terms of the NICE and SIGN guidelines, which allowed us that this should become a standard of care now. But what we didn't understand is how it's going to affect the long-term economic aspect of care for these patients. And that prompted the Department of Health to fund a $2.5 million trial, and we are recruiting patients from 35 centers. And I have no doubt that this would be a standard technique in the next few years, and it would save a lot of money to the healthcare organization. So this is an example that how a simple idea can transform the healthcare, which improves the quality of life and becomes less expensive for the healthcare. But can we avoid putting this chemical into the bladder because it has got its own side effects and also it has cost? And we in Dundee have used a different kind of laser called Raman spectroscopy and made it a confocal, it's small area which can be scanned at the same time. And we use that laser into the bladder, and these are two normal and abnormal areas. And if you get this laser touch the normal and abnormal area, you get two kinds of pictures. One is the blue and the other is red. And by the statistical analysis, and by validating methods, we have proven that it can differentiate between cancer and normal cancers. We are developing a number of platforms using the advanced techniques and improving this technology using nanoparticles and using advanced Raman. And hopefully, we should be able to bring this technology into clinical practice in the next few years. And that would transform the care. You don't need to come to the hospital for a treatment. You can have an outpatient and go home on the same day. We also have interest in biomarkers. That means we don't need to do a telescope examination. We can use the cells and we can use the urine samples to know which cancer is there. And one of the interests which we have developed a platform of research recently is volatile organic compounds. These are similar compounds like somebody who has been driving and get tested for alcohol. Similar way, the cancer cells, when it breathes, it releases certain chemicals. And if we have a platform of detecting those chemicals, then we can differentiate between cancer and normal, and we can also characterize depending upon the type of chemicals which are released from there. And this has a potential to get miniaturized into small devices like mobile phone, which the patient can take home and detect their and monitor their own cancers. And there's a clear benefit that if you allow patients to take care of their own diseases, then the quality of care improves. So this is another focus of research which we are pursuing in the University of Dundee at the moment. We have created a lot of areas of advanced knowledge and rare cancers. And one of the examples is somebody with this rash presented to me a few years back who had seen at least 4 physicians and got different creams and gels to apply. And when I looked at it, it appeared to me something abnormal. So we did the biopsy and through a number of genetic techniques and immunohistochemical tests, we established a link of this rash with bladder cancer. And now that would be forming guidelines for somebody who would be presenting in future, because these are very rare cancers, but at least it's now published and it's in the public domain, and that could guide the clinicians to fast channelize these patients through the care. Our detection remains a problem, not only prostate cancer, not only bladder cancer, but also renal cancer. For example, this gentleman these 2 patients who presented with abdominal pain, but had the scans. And if you look at the scans, you would see that there's a small area here which is abnormal, and there's a large area here abnormal. So purely based on intuitions, you would suspect that this gentleman is going to have, or this patient is going to have a bad disease, and it would progress fast. But now 10 years down the line, this stays like this. And this gentleman who had a small lesion, it progressed fast and causes his death in 2 years from this lesion. So clearly, we don't understand what's the behavior of cancer. And most of the decisions which are made in clinical practice are based on size or how it appears, which is less than ideal. And we need some kind of mechanism to characterize these cancers. Prostate cancer is diagnosed by a blood test which comes from which is a protein which comes from the prostate. It doesn't come from the cancer. And also there are a number of biopsies which we do from the back passage route to find out where the cancer is. And this poor organ gets bombarded by a number of biopsies without realizing where the cancer is. So we need better techniques here. And what we had done in Dundee, we use the genetic techniques. We take the blood samples and tissue sample and look at some of the areas which in the chromosomes, and we test these chromosomes for deletion. For example, this is a 9p chromosome in patients with renal cancers. And we have shown over the follow-up of 10 years that if this gets deleted, then the people have a worse outcome. So if somebody had a surgery and we test this for this, and we know that this patient is going to have poor outcome, we can combine the number of treatments together or add something to the top of surgery and improve the outcome in future. And this is something which our research has shown. But we also realize that if there's a cancer here, it has a number of areas which are growing. It's not as homogeneous. It's a heterogeneous disease. And that's a challenge for us. And all the genetic tests which have done so far have not achieved what they should have achieved, because we don't know how the cancer is in different areas. The similar cancer has different clones of tumor cells growing. And how can we image the environment or microenvironment of cancer? And that has been the focus of our research. And we have used a number of techniques. But this is something which is used clinically at the moment, and I would bring that first. It's MRI scan, and there are a number of ways by which we can characterize the cancer. MRI is based on how the protons spin in body, and how water has got more protons because it has got 2 hydrogens. So when the cells get packed in cancers, the water restriction, movement of water is restricted, and that's picked up by MRI. Also, when the blood supply, which comes to the tumor, gets altered because tumor is trying to get nutrition, it grows its own blood supply. So there are changes in the way the contrast is handled in the tumors. The way the cell is utilizing the metabolic mechanisms is also changed. So the choline and citrate ratio changed. So there are a lot of things which are happening in cancer cell, and we combine that information together, and then we can predict which cancers are good and bad. And in Dundee, we have used this in a research setting, and I'm getting a lot of requests from patients to get this into clinical practice as soon as possible, because we can really differentiate between the good cancers and the bad cancers, because good cancers are not going to be seen by this scan, and the bad cancer would be picked up. So some of the damage which was done by PSA testing would be offset by this technique in future. However, ultrasound is not for everybody. Some of patients who have hip replacements, cardiac pacemakers wouldn't be suitable for ultrasound. So what we have done is we have investigated a number of techniques which are in the research lab, right from the optical coherence elastography with my colleagues in the engineering department. We looked at other techniques called 2-photon imaging and multi-photon imaging as well. But something which we are using in clinical is called shear wave elastography. This is the same ultrasound which is used for monitoring pregnancy, but in a slightly different way. It's like you drop a stone in the water, you get ripples. And what we have used is this different kind of ultrasound scan, which creates the ripples and also images those waves. And depending upon the stiffness of the tissue, you get a red area on the top and you get a blue area. Now, with the best scans, you cannot actually, with the best radiologists, you can't tell with a normal scan where the cancer is. With the help of this scan, which is a shear wave elastography, you can actually point out where the cancer is. And if you put the cursor on this area, you can tell what's the degree of stiffness, and that degree of stiffness would correlate with the cancer. So if you can see the cancer, you can treat that rather than removing the whole gland, and that would save a lot of side effects pertaining to the surgical procedures which we do at the moment. But cancer also feeds to the surrounding tissue, and this is something which is new. When the organ has a cancer, it's starving. These cancer cells are starving, so they try to buy in from the surrounding tissue. And one of the commonest tissues is fat. And our research has shown that the periprostatic fat, if it's more in amount, it would feed into the cancer and allow the cancer to behave badly. So this is a new concept which has come up, and using the imaging, we can actually estimate the amount of fat and tell that this cancer is going to behave badly and this would need certain urgent treatment compared to somebody whose fat is low volume. We also try to characterize the fat and classify the patient depending upon the kind of fat around that organ. And we have seen that the total body fat does not correlate with the aggressiveness of cancer in prostate. It might for other cancers. But this is something which, through our research, has shown in a very simple test which could be used. We are also looking at the ways by which we can transform the inpatient care to outpatient. And the way we do it is by simple ultrasound techniques, which you can see it. We can use the monitoring of the cancer as well as the treatment. And this we have recently developed as a platform for Futura project. And we have submitted a report to a large consortium. And the report has been excellent. And we have been asked to put another Trans-Futura project for a multi-million project. And hopefully that should get translated into clinical practice. The Dundee has been famous for minimally invasive surgery, and we have made a number of advancements here, and we have been leading center in the world. But more importantly, we have innovated a single port where you can see the surgery can be done through the small hole in the belly button, and that will reduce the pain, enhance the recovery, and transform the care. And that has been in news for Nine Wells Hospital because Nine Wells Hospital has been the pioneer in this technique. And finally, we have a duty to teach and train our trainees, our next generation, because there should not be a technique which would die with the surgeon. It has to be transformed to the younger generation. And we are in a very good position in Dundee, in fact, the leading position in Dundee, to have the resource for teal cadavers and other things to run a center which attracts people, not nationally, but internationally, to come here and get trained in Kusheri Skills Center for surgical procedures. We also contribute and house a lot of students who are coming from international area to do research into undergraduate, postgraduate, and postdoctoral courses. So in short, over the past 6 years, and our program is still in childhood, we have been able to have some of the cutting-edge research which has not made national impact, but also the international impact. Thank you very much.